with that is it has a huge sodium load. And so that you can get it, you can run into volume overload with it. So be careful with that. And also the iron. So be careful with iron and if they're going to use some type of acid suppression. So have them space them out. All right. Sucralfate, not used very common. What do you remember about sucralfate? What would be the good thing about sucralfate?
Isn't it like a binding?
It is a binding. What does that mean? What do you mean by binding? Just tell me more. It's true.
It like protects the lining of the stomach, but it also like binds. I don't know.
It will bind to those. It will bind to abnormal areas, so erosions, and so it stays local. It doesn't get absorbed. So that's a nice part, and that's why it's more preferred. People don't tend to use it very often because it has to be dosed like 4 times a day, 3 to 4 times a day. But it can be very effective, especially if there's ulceration or even gastritis. It will also work. So sucralfate, you see class B, so safe drug for pregnancy. Now, if you have to go beyond that, then that's where the data is either going to indicate that there are effects in animals that have been published or limited information in pregnant women. These next agents you would avoid in early pregnancy, so in the first trimester. Luckily, most women are not going to have GERD in the first trimester. It tends to come after 20 weeks and longer. So the next are the H2 receptor antagonists. They would be preferred. Ranitidine out of that group, and this is important, has the data behind it. So not all of these H2 receptor antagonists are equal. So ranitidine has would be the recommended out of that class. What do you remember about the H2 antagonists in terms of acid suppression? If I've got heartburn, I want relief right away, what am I going to take? An antacid, okay? Well, so in terms of PPI and H2 antagonists, which are faster in onset, H2 receptor antagonists, and then PPIs. Go back and read that information. So just review that. Read through it. Okay. So ranitidine, first line, famotidine, over-the-counter. Ranitidine, over-the-counter. Famotidine would be one we would recommend behind ranitidine. I would tell you, if one doesn't work, it's the rest of the class probably is going to work. These drugs usually are short-term. They've got good onset, but we can't use them long-term because they lose effectiveness. However, in this case, it's a short-term. You're not going to use these for more than a few months or a few weeks. Avoid using Axid. Now that one's a prescription. It has data that makes it less desirable. Promotility drugs, so metoclopramide could be considered, can increase GERD. The proton pump inhibitors is our last choice. So if you looked at, most of them are B except omeprazole, and omeprazole is the one over the counter. And it's a class C, or category C. So avoid those during first trimester. The other PPIs would be lansoprazole, Prevacid, they can get over the counter, pantoprazole, and then Prilosec is over the counter as well. Okay. So if you are dealing with, if you are in a practice where you're dealing with pregnant women, sometimes it's good to have this conversation ahead of time. Because the first people they're going to listen to is their mother and their girlfriends. Okay? So they may not bring it up with you. The one thing I found is that with my OB, he would go so fast that he would be in and out of the room so fast that finally I just said, I have questions. So he got used to where he would ask me first. So I would always write out my questions, and then I could make efficient use of his time, and he was more likely to listen. But these would be the things for women to have conversations with their OB or whoever is overseeing their pregnancy about what to use and what would be safe. Okay, so that's GERD. So the biggest things is differences here. Differences in terms of general population and what is in pregnancy. I will ask you specifics about this. Write it out to the side. I will ask you specifics. You will have to know specific drugs and identify them as the drugs that can be used or avoided. Okay, constipation, very, very common. That progesterone goes way up and it slows down the gut. So we're going to use the same kinds of things that we did in the past. Lifestyle would be really important. So one is lots of fluids. The other is to stay active, walk. The other would be fiber. So using food if you can. Would be the best source. And they're listed there for you. On the second page would be laxatives or bulk producing products. So laxatives, we really don't want to get into those if we can't, but if we have to, the place to start would be with the psyllium products. Okay, so like Metamucil, or polycarbophil, or methylcellulose. All of those are going to be plant source items that are going to stay in the gut and they're going to swell, so they'll need lots of fluid. So they'll need to be drinking a lot of water when they're taking those. Again, go back and read this information in the, because I gave you a lot more on mechanisms, and I gave you pictures on them in the GI module. Osmotic laxatives, we want to use these judiciously, okay? Because osmotic laxatives do just what they say. They draw water into the colon, and then they cause an ability to pass the stool, soften the stool. So, but too much osmotic laxatives can then lead to dehydration. So you want to use them. First source would be Miralax. So I go to an easy one to use, over the counter. Lactulose, same type of process or mechanism. Sorbitol would be another one. Those are all osmotic laxatives. Stimulant laxatives, the least we want to use. Okay? They irritate the gut, they make the gut move, but overuse or overdependence causes overdependency of the gut on those being present in order to move. And they can produce diarrhea if overused. So here we're looking at 2 or 3 times a week or less. Senna is probably the safest of that group. Again, over the counter. Bisacodyl would be a suppository. Cascara would be, the black and white, Milcabag with Cascara. We always call them black and whites because that's the way they look. Stool softener is probably a marginal value. They're just not strong enough. They just don't do enough to soften a hard stool and to pass them. Laxatives to avoid. I can guarantee you I will ask you about these. They're too important. You need to know. So castor oil will stimulate uterine contractions. Saline osmotic laxative. So this would be your mag sulfate. This is the mag citrate that they can buy over the counter. Okay, green bottle, 10 ounce. You don't want them to do that unless it's under your authority or physicians or their OB. Mineral oil. So what will happen is you get that decrease in fat dependent vitamins. And it causes a problem in the infant as well. So mineral oil and then aloe. Aloe is very popular in terms of, it's like one of those things that does everything, cures everything. So really important to avoid that during pregnancy. Know those. All right. Last is the internal hemorrhoid treatment. Again, I gave you these in GI. You do not have to know the products, but I would like you to be able to match up, just like we did in GI, what the ingredient is and what it does. Again, if you're over by the hemorrhoid products, pick them up, look at them, and see if you can identify what they are. So you usually have, and most of these products will have multiple, and will include most of these, but not all. So there'll be a skin protectant. There will usually be some type of anesthetic in there. You may or may not see an anti-inflammatory like hydrocortisone. If it's in there, it will usually have it in the brand name, like Anusol HC. So it'll usually tell you. Or in astringent. So your skin protectants, those are usually, and you can have multiple of those in a product. So aluminum hydroxide, cocoa butter, makes sense? Glycerin, kaolin, lanolin, petrolatum, something that makes the passage of a stool easy. The anesthetics, you should be able to recognize those. Most of them will have cane at the end of them, benzocaine, Novocaine, Paroxine, I don't know, it doesn't fit them all. Then your hydrocortisone is your only anti-inflammatory. The one to avoid, and the one I asked you about on the last test, is the vasoconstrictors. Okay? Because they'll absorb them and it'll affect placental unit. All right, questions about those? I think that's all the general type stuff. Okay, so the next are medical conditions or labor and delivery or postpartum. So that's what we're going to launch into next. Did you talk about treating high blood pressure? You haven't talked about eclampsia or preeclampsia yet? Yes?
Not in detail.
I think it's a complication of pregnancy.
You've done that? You did that today?
Yeah.
Either today or tomorrow.
That
was 2 weeks ago. We didn't have a treatment.
Have you done preeclampsia?
Not the treatment.
Not the treatment, but you've had it ClinMed. So what I'm asking is ClinMed.
Yeah.
So you've done preeclampsia and eclampsia. Okay. So hypertensive disease of pregnancy. So several, that very first part, I'm not going to ask you over, but it clarifies the different categories. Okay. So you can have hypertension before pregnancy. You can develop hypertension during pregnancy, so that's the second one, gestational hypertension. You can have preeclampsia, eclampsia. So that has its own. Remember, it is nuanced. It's hypertension and proteinuria. End organ dysfunction. So which end organs are we most worried about? Kidneys. After 20 weeks. Eclampsia is then when seizures occur, right? Okay. Women don't have to have preeclampsia to develop eclampsia. And in preeclampsia, eclampsia is superimposed on chronic hypertension. Okay, so it's kind of a progression. So with chronic hypertension, that is when they have hypertension before they get pregnant. So here, what would you think the issues are going to be?
Fluid, like retaining.
Okay, fluid. Well, the number one thing that would strike me is what have I got them on that they can't take during pregnancy?
An ACE or an ARB.
Okay, so an ACE or an ARB, or if it's a beta blocker, look back at your list. I'm going to then before, so this would be good that they plan a pregnancy, we can switch them, okay, to drugs that they can take while they're pregnant. The goals during pregnancy are different. So did you all talk about different goals? So you've talked about hypertension in pregnancy, talked about preeclampsia. Was that not a discussion prior to? Okay. So one of the things we don't want to do is we don't want to drop the driving force through the placenta, right? Okay. So we're going to keep their blood pressure. We're going to tolerate a little bit higher blood pressure in pregnant women, and at the same time try to avoid in-organ damage. Okay. So sometimes if women are mildly, this is going off this, so these would be some scenarios. If women are well controlled, they have mild hypertension, they may take them off the drugs during early pregnancy because their blood pressure is going to drop. They get that big blood volume expansion, so a lot of times blood pressure will change. If they're on thiazides prior to pregnancy, sometimes we continue, but we usually do not start a diuretic. Okay, what are you guys laughing at?
We're looking at
It
the
isn't
complications of pregnancy. Yeah.
Okay, so what did you see that was funny? Tell
I
me.
just don't remember going over it, so that's
We
why I'm
haven't- we
not.
haven't-
We're confirming that we did have a lecture.
Why did they do it the first way?
Because that's what
She
she
was
was,
having a
baby.
That's right, that's right. She was gonna have the baby on the day she was due date was the day she was assigned. Okay,
Yeah.
all right,
And the baby was running late.
So we're a little rusty.
okay. Okay, so they may take them off the medicine and see how they do. We don't start a diuretic during pregnancy, but we may continue it if they have been on it to start with. We will change our, so run down through her lecture and see if she gave you a different, because it used to be 100, less than 150 over 90.
She said she was at 160 over 105.
Yes.
No, it's,
But, well, is that for treatment or treatment goal? I mean, is that when to
Control
start
blood pressure
treatment?
less than,
over 110.
it just says management, control blood
Keep
pressure
it below
less
160 over 100. Yeah, it used to be 100. So I wondered if it had changed. Okay, so see the difference. So know that that is a difference in terms of what you treat, because most of the time, if somebody walked into Good Shepherd with 160 over 105, what would Professor Reggio do? You would treat them. You would start them on probably 1 or 2 drugs. Okay, so difference there. Okay, so the complications are, so let's go under goals. Goals are to, one is you want to keep them, the complications, cerebral hemorrhage. Want to prevent that. Fetal complications, so growth retardation. So if you have constant vasoconstriction in all your arterial beds, less gets to the baby. Okay, so it makes sense why they might be small for gestational age. Okay, so we want to keep them, we want to normalize that. We want to prevent that eclampsia, preeclampsia. Because with preeclampsia, what's the definitive treatment? Delivery. Okay, so that may mean you have to deliver a 31-week-old or a 33-week-old. Okay, and the problem we get into there with early delivery is in what organ? Lungs. Okay. So we want to try to avoid that. Placenta, abruptio placenta, what is that? Placenta comes away from the wall of the uterus, so we usually have to deliver them. Cerebral hemorrhage, preterm labor. Okay, so lots of complications that go along. So hypertension, mark in your brain, really important in pregnancy. Decisions to treat, level of blood pressure, most important factor. So go by what she has told you. We don't want her to stroke. Okay, so medication options. So we use oral agents. In the past, the old agent was methyldopa. We hardly use it anymore. It has to be used multiple times, a little slow in onset, has side effects associated with it that not everybody tolerates. So an older drug can work. Most people don't use it as much anymore. Labetalol would be one of the drugs of choice. ACE inhibitors are out. Think about all the categories we've knocked out. ACE, ARBs, some of the beta blockers. The others down there, direct renin inhibitors, we don't use those very often. Elaskiren, the mineralocorticoid receptor antagonists like spironolactone, we're not going to use those. So the calcium channel blockers can be used. You'll see it's mostly verapamil, diltiazem, and nifedipine with sustained release. You would not use the regular release. The labetalol is preferred. Remember, it's an alpha and beta blocker, so it has dual action. Seems to preserve blood flow to the uterus better, faster onset, well tolerated, doesn't cause congenital anomalies. If you look down at the bottom, antihypertensives for severe is IV hydralazine. What do you remember about that one? It's a very old drug that has come back. Do you remember what type of drug it is? It's a direct vasodilator. Peripheral. So most of its side effects are related to reflex, so reflex tachycardia. It's a potent vasodilator, so it causes a lot of reflex tachycardia. Very good, very effective. So IV hydralazine, IV labetalol. Now, going back up, did you talk about glucocorticoids for maturation of the lungs? Okay. So the two that have been recommended and used over the eons are betamethasone and dexamethasone. Did she talk about doing ultrasounds to see if the baby can do spontaneous breaths? Did they talk about that? Yes?
Yeah.
Okay. So I know they do that as well as and use the steroids. So the thing with the steroids is timing. So be sure you look at that. Now the steroids you can use and the timing. So it's usually in the in a week or less before they're due. So sometimes you don't have that long. So 24 hours, these will also have good effects. Questions about those? Okay, we're going to spend quite a bit of time on magnesium. So next page. So magnesium, two things we're going to use it for in pregnancy. One is, again, tocolytic. We're going to slow down preterm contractions. Can't use it forever. It's good for a short run. And it's also seizure prevention. So in women who are preeclamptic, then they are probably going to start them on magnesium if they're admitted to the hospital to prevent the seizures. So it's preventative and it's treatment. So distinguish between the two when you're thinking about its use. Okay, so we treat preterm labor in order to prevent labor, and we use it to prevent seizures. But we can also use it in seizures. In fact, now they're starting to look at mag sulfate in people non-pregnant, women and men who have seizures that aren't responsive to other agents, interestingly. The most common regimen is this. We always give a loading dose. That loading dose is usually in that 4 to 6 gram range. You have to have good kidneys to avoid toxicity with magnesium. Really important. Okay. Almost always the continuous dose is then that 2 grams per hour. You'll see that same regimen again. It's always going to be given through a pump. So they're going to use an auxiliary line going into, or peripheral line into an IV that is pump controlled. because if you give too much, you can kill them. And so you've got to know the signs and symptoms. What do I monitor and when do I stop? And when do I give antidotes? So, anybody remember the normal range of magnesium, normal levels? That's potassium. 1.5 to 2.5 milliequivalents per liter. That's normal. Most of the time with these therapies, we're going to be raising their magnesium up into around 4 to less than 8. So you'll have to write this down because I didn't put it in there. So how does it do it? How does magnesium work? Well, it's a calcium antagonist. That'll be easy to remember because if we give them too much, we'll give them calcium gluconate to recover. So if it's a calcium antagonist, what's it going to do to muscle?
Relax.
It'll relax it, and it's specific for smooth muscle. That's why it works, because the uterus has smooth muscle in it, and so that's why it's a tocolytic. Okay. So smooth muscle relaxation. It's also a very good vasodilator. And it also works on the NMDA receptor. Inhibits it. Do you remember any drugs? Do you remember where we talked about that?
In the gut?
Not the gut, but in neurology we talked about topiramate. One of the receptors it works through is that NMDA receptor. It's kind of a new receptor that people have started looking at, felbamate, which is one we didn't talk about, and another one. Oh, that one it's like Pampernel. It's not exactly. But, so these are newer agents that are coming out. So it works through all of those, and that's how it acts as an anticonvulsant, is through those NMDA receptor antagonists. So multiple effects within the body that magnesium has. So what do you need to monitor? Extremely important. One is deep tendon reflexes. Those are usually the first to go. Patellar is usually the one that you will monitor, and when it goes, you stop the drug. So patellar tendon reflex, and that's when the levels get above 8, is when you'll see that. You also monitor respiratory rate, because too much of this drug will cause respiratory depression. There you would give a calcium gluconate. That comes at higher levels, what, at 13? Yeah, above 13. Tetany can occur, so also calcium gluconate would be your rescue there. So hypocalcemia can occur. And then following your eyes, nose, your input, output, urine output, so kidney is important. Be sure you know those. The levels, what do you monitor, and how do you tell when there is a problem? Okay, questions about magnesium. If you deal with women's health acutely, you will see it a lot, so be sure you are familiar with those basics. Okay, gestational diabetes. When I was in your position, about 2% of pregnancies were gestational. Now it's 6 to 7%, and I've seen it higher listed in some subpopulations. So gestational diabetes, it's important to, just like with hypertension, to remember it is diabetes that first shows up and diagnosed during pregnancy. Pre-gestational diabetes would be a woman who has type 1 or type 2 and becomes pregnant. We don't call gestational type 1 or type 2. We don't categorize them that way. And so gestational occurs during pregnancy. So pregnancy is a very insulin-resistant state because the body is going to keep those nutrients going towards the fetus. Like Shannon and Thatcher told you, I got extremely skinny, but I had a normal-sized baby. The body will keep that, will preserve that. So you produce hormones that make you insulin resistant. That human placental, what's it called, HPL, comes in the later part of pregnancy, causes lots of resistance. Most women can overcome it. They can produce enough insulin to overcome that resistance. The women who cannot are women who will then end up with gestational diabetes. The same risk factors that you have for diabetes are also the ones that you'll see with gestational. If family history is huge. If they've got a mom that had gestational, has type 2 diabetes, they are very likely. They don't even have to be overweight. I would say half the women, I did a lot of counseling of women in gestational diabetes. I bet you, probably not half, a third were skinny. They were like Hannah size. Tall and skinny. But most of them were, a lot of them were preemies. They were small for gestational age, and so I think it's a lot of that you're dealing with a smaller population of probably beta cells. And you put enough of a stress on them and they then can't produce enough insulin to overcome the resistance. If a woman has one gestational pregnancy, her likelihood of the next one is goes up by a third, like by 30%. So very important to counsel them in between. The one thing that will decrease their risk, just like we talked with pre-diabetes, is exercise and get the weight off. So spacing their pregnancies and being active and getting all their that back down to a pre-pregnancy weight will help. And then we can also work with them within that second pregnancy. So why do we work? Yeah.
Is it the spacing itself that matters, or that it gives you enough time to get back to
Gives you
normal?
time.
Okay.
Gives you time. So the consequences of gestational are having a large baby. Large babies would be defined as 10 pounds and over. They're also in the percentile, like 90th percentile and above, is a large for gestational age. And macrosomia, so a big size baby. The number one relation in the pregnancy to that macrosomia is what is their blood sugar after they eat. And so we'll target a lot of our therapy just towards that. So it's going to look different than the way we treated people who had diabetes. So hyperglycemia, number one, also would be a big weight gain. Did you all talk about weight gain based on pre-pregnancy weight? Okay. So obese women don't need as much. So a lot of the weight gain is due to putting down fat, getting ready for breastfeeding. So that's why obese women need less. So those large for gestational babies, macrosomia, C-section rate goes way up. Dystocia, what is that? Shoulder dystocia. Shoulder gets stuck so they can get broken, dislocated. Dr. Britton's family, he is the runt of the litter. They are all, his dad was probably 6'4", 6'5", his brother was 6'4", his niece, his brother's daughter is 6'3". I mean, they're all like, his sister's 6 foot. They're all tall. And all their babies big. So Dr. Britton was 10'4". He was 10 pounds 4 ounces. Oh my gosh. How big was your baby? He was 7 pounds, but he was a month early, so yeah, really. So his brother was, I don't know, between 9 and 10 pounds. But she said, my mother-in-law told me, she said, I brought this baby home, first baby, I didn't know anything about him. She said he cried all the time. Well, he had that shoulder dystocia. Took about 2 weeks before the doctors figured it out. So birth trauma, very common to mom and babe when the baby is too big, so that's why C-section rates go up. Brachial plexus injuries, fractures to their shoulders and arms can occur. Preeclampsia goes up, polyhydramnios goes up, stillbirths. Nobody knows exactly why, but stillbirths are much higher in women who have gestational or diabetes and are poorly controlled. Neonatal morbidity, so hypoglycemia, we'll talk about why that is. Their hyperbilirubinemia, calciums go down, magnesium go down, respiratory distress. So lots of reasons to focus on the gestational woman. Most of the time we can have, if she's identified early and treated well and she follows therapy, she can give birth to a normal size baby. So the recommendations, one thing I will tell you that if you're dealing with women who are pregnant is that the rules change all the time. And the consensus on exactly how to do things, screening, diagnosing, are also different. There's different camps. They're very close, but there's differences. How much sugar do we give them as a load for an oral glucose tolerance test? How long do we wait? Do we use one abnormality? Do we use two abnormalities? There's all these little nuances. So I'm going to tell you one way, and I'll give you some ways that those differ. And then treatment. Okay, so the recommendation is that all women between 24 and 28 weeks gestation be screened. Okay, so it is important to keep that terminology, screening versus diagnosing. We screen, and then any women who fail a screen, then we do a second test to diagnose. So that's called a two-step method. Some people do a one-step method where they will give them a different amount, they'll test them at different times, and they will call it based on one. I think the majority of people follow a two-step method. So we screen them with a oral glucose tolerance, and then if they fail that, and I'll show you on the next page, then we'll do a more diagnostic test. Now, we've gone all over the board about who do you test. Do we test everybody? Do we just test high risk? So for a while, we tested everybody. And then they decided, oh, that costs too much money. Women who are less than 25 years of age, they're skinny, there's no history of diabetes. Well, we're not going to test them. Well, they did that for a while and figured out that they missed people, so then they've gone back to it. So now the more conservative approach is that every woman, 24 to 28 weeks, so that's pretty far in. You're in your third trimester by the time they are testing you. That's when those hormonal levels go up high enough that resistance really becomes evident. Now, when you're pregnant, when you go in, they're going to test your urine from day one. If they find sugar in your urine, they'll do other tests. Because you may have women who are diabetic that have not been diagnosed. Okay? Start putting some stress on them, and then it shows up. Or they had it, never were diagnosed to begin with. Questions about that? Okay, look at that next page then. This is the flow. Most people use, some use a different amount, but most people use a 50-gram oral glucose challenge. Don't have to fast. You just come in, you drink this stuff about an hour before, and then they'll look at what's your blood sugar after that. I didn't put down the time. I think it's an hour or two. So then they're going to look at if you're less than 140, you just go on into regular care. Then it's that group in the middle, 140 to 179, they will schedule them for a full-blown oral glucose tolerance test. Some are you shaking your head. If it's greater than, and here it will differ, greater than 180 or 200, some providers will just call it gestational at that point, especially above 200. So let's look at, let's follow that middle group, because that's probably the largest number of women. Most women are going to be normal, but the there's a lot that will be abnormal on screen that you'll then do a diagnostic test. So then you bring them in, you give them 100 grams. And then there they have to be fasting. Some providers will do a blood sugar before and some will not. So some will do a fasting, some will not. So then you look at that 1 hour, 2 hour, and 3 hour. These numbers even vary between groups. There's 2 camps. So the other group has a higher number. So if 2 or more values are met, and some people just use 1 value, if 2 or more are met, then treat them as gestational diabetes, and they'll start them with diet usually. If 1 is elevated, then they may go ahead and treat them at least with diet and look at their blood sugars after they eat. Know that pathway. It's very common. Majority of women will show up normal out of that group. Then you have the group that is, you're going to call on based on the screen. Then you can look at a fasting blood sugar. The blood sugar goals in pregnant women are different from non-pregnant. So less than 95. Oh, they're saying if it's greater than 95, then they're going to call it as a gestational. If it's less than 95, then they'll do an oral glucose tolerance test. Because it may show up if you stress them at a different hour. Okay? All right, so treatment. Diet and exercise are foundational. You can control a lot of women with diet. So usually what we will do is we will just modify their carb intake. We'll stretch it out over the day. One thing that these women tend to get in trouble with is they get ketotic early in the morning. So we will teach them to spread their carbs out throughout the day, make sure they get a snack at night. And usually, and with walking, most of them can keep that blood sugar at goal. Look at the goals under that third big bullet. So fastings are 60 to 90. What is it normally for a non-pregnant? Treatment. 80 to 130 for treatment, 70 to 99 for diagnosis. So here are the most important are those 1 and 2 hour postprandials. Be sure you know those. So we work with them. We'll teach them how to use a meter and we'll have them check. And we want to keep them at less than that 140 at the 2 hour mark. You need to write out to the side, this is the #1 intervention that will keep that baby from getting too big. The higher that number is after they eat, the more likely that baby is going to gain weight. So what we'll do, let me finish this thought now. So then what we'll do is if they're if they are running slightly above that, we'll adjust their carb intake. Some of these women will go down to about 40% carb of their diet, and then we'll make up the rest with fats and proteins. As long as we can keep them there, they're good. Okay? But if they can't, then we'll move to medication. All right.
I don't know why this just dawned on me, but don't yell at me because I didn't ask it in diabetes.
Have I ever yelled at Kristen?
I wrote
Have I ever yelled at anybody in here? Okay. All right.
So when we say 1 hour postprandial, is that one? So if I start eating at 5, I take it at 6, or if I finish eating at 5:30, I take it at 6:30. Is it when you start eating or when you?
I've had very few people ask me that. Usually it's from the time you start to the time you finish. Most people don't take that long to eat. So it's usually, I guess if you drug your food out over a long period of time, most people can't keep up with that.
Okay.
Do you have any other? If you eat at noon, I want you to test at 2 o'clock. Because then you'll catch them between that 1 and 2 hour, if it makes that big of a difference. Okay. So then what do? So normally we would go to like metformin, right? Here, because we want to control postprandial, we're going to go to short-acting insulin. Okay. Make sense? Yes. Okay, so we are not going to a basal. We're not gonna put them on oral usually. The preferred drug is insulin. It's the most powerful, and so that's, but there is big divisions in the gestational diabetes group about whether to use an oral or use insulin. So we're gonna use insulin. Again, we'll put them on we'll try to put them on set amounts of carbs, and we'll give them a set dose of preprandial insulin. Then we'll have them check after. If we cannot control those blood sugars, because they'll get more and more, their insulin requirements will go up as they progress in pregnancy, then we'll add a basal. Okay. So let's look at the insulins we'll use, because that's important. So the insulins we'll use are going to be two of the analogs, Humalog and Novolog, or regular. Now again, the reason for that is we know they're going to cross the placenta. So are they going to cause trouble? So it's really important here to pay attention and use insulins that have approval for pregnancy. So because all of the analogs will cause antibodies to be formed. Because they're just different enough that, but most of the time it doesn't cause us trouble. So we can use those analogs. They're shorter, they're more predictable. They don't cause as much hypoglycemia down the road, which regular will. But regular can be used. So we're going to use it with the different meals, depending on the patient's response. So we may only use it with one meal, or we may use it with all 3 meals. Then we'll add, so know which insulins can be used. Basal insulins, probably the preferred, and among most OBs that I work with, was NPH. Levemir has approval for use in pregnancy. Lantus does not. It's actually, I think, a grade C. That's what they're doing? Yeah. So NPH and Levemir are your basals. All right. Now, orals. So glyburide has been long used. It's a sulfonylurea. How do they work?
Stimulate the beta cells.
They stimulate the beta cells to do what?
Release insulin.
Produce insulin. Okay. So for mild GDM, a lot of people like to use glyburide. Many of those people will go on to need insulin. Again, as they progress in their pregnancy, their resistance will go up. So probably the people most respected and the leaders in this area are still insulin advocates. But a lot of glyburide is used. The only problem is it does cross the placenta, and it stimulates those beta cells in the infant. So once they're born, you have to pay attention and give them food, because it's such a long acting that they will get hypoglycemia. Whereas if they're using like an analog insulin, it's so short, probably won't make a difference. But the glyburide you have to pay attention to. So maternal and neonatal hypoglycemia are more of a risk with glyburide. The other is it may just not have the power to keep their blood sugars under control. So monitoring is a must. Metformin's been a favorite. The problem with metformin is its power. A lot of it just does not have the power to keep postprandial blood sugars down. So it's not teratogenic. It can be effective, probably very mild cases. Doesn't have the hypoglycemia, doesn't have the weight gain potential. Okay. Those are the only drugs that are used in GDM. Okay. Questions on those?
I have a question.
Yes.
It says in here that you can use it in the second and third metformin in the second and third trimester. Is that because it's just diagnosed then, or is there something with the third
Right.
trimester?
Right. You're not gonna see, if it's GDM, if it's in the first trimester, it isn't gestational.
Okay.
Now, if a woman has prediabetes or she has type 2 and she's on metformin, you do not have to take her off. You can leave her on during early pregnancy. My approach, because I was in a population where this was fairly frequent, is when I identify a woman who has gestational, I will usually just do a general, here's what's going on, here's what's happening, and then I get them into an OB group that is geared to that, because they'll have nurse educators, especially if they're going to work with insulin. It's just an ongoing support system that they need in order to keep adjusting. So know where, if you're dealing with women, high risk, know where your OB support is. Okay, RhoGAM. So I understand you talked a lot about the use of RhoGAM in Rh negative women. So let me just, questions about that, and I'll just give you the kind of the things they probably haven't gone over. Who's it indicated in? When would you give it? Mom is negative, that's the first, where you start, right? Mom has to be Rh negative. If the baby's Rh negative, the mom's Rh positive, we don't care. So Rh negative mom has a Rh negative positive baby. So what's the problem there?
Antibodies.
And when will that occur? You have to have some type of encounter between mother and baby blood, right? If that never happens, my mom's Rh negative, she gave birth to 4 Rh positive babies, never had a problem. Okay? But if there is a mixing of blood, if there is a miscarriage, if there is something that happens during the pregnancy, that there is an exposure, that's when it's likely to happen. Okay? So Rh negative moms are going to probably receive RhoGAM at some point. So if looking down on page 23, I've given you a flow sheet there. Probably others did as well. So it is a blood product. It's an immunoglobulin. It comes from a single source. So it's very reliable. But the problem is it still can carry viruses. It still can have infectious disease transmitted, so it's not without risk, but the risk is low. Let's see. So there is the usual dose is 300 milligrams. It's given IM. We never give it IV, and there is a microgram, a 50 microgram for. I'm not exactly sure. I think that's probably maybe done more in miscarriage or other obstetrical problems other than delivery. You would not use it in the flow that I've given you above. It comes as pre-filled syringe, so it's usually ready to go. Most common side effects are just injection site reactions. You can have systemic full-blown reactions. They are extremely rare, though. Questions about RhoGAM? Okay. Labor and delivery. So I'm giving you definitions at the top. Tocolytic. So here comes mag sulfate again. Everything we talked about plays out the same here. The dose is the same, the continuous infusion. So here we're using it to decrease preterm labor. So monitoring would be the same, side effects are going to be the same, everything is similar there. At the bottom though, I did put a caveat, number 9, fetal magnesium serum concentrations will go up, and so the baby will have effects of that for 3 to 4 days. So hypotonia is calcium and sleepiness. I put the beta agonist in there. I would assume they are not used at all, but they were a big drug in the past that we gave to women to decrease. Ritidrine was one of them. Terbutaline was also used. many side effects and many bad things happen, so they are not recommended. I doubt that you would see them these days, but I'm putting them in there is that we don't use them anymore. Nifedipine can be used. It's more of an last result, drug that you would use if you're for some reason couldn't use magnesium, but it is here you're using the regular release. So it's a calcium channel blocker. So you're decreasing smooth muscle, just like you are with the Max sulfate. Corticosteroids we already talked about. Okay, labor induction. Did you all talk about these products? Have you talked about labor induction yet? Gotten there yet? Nope, not. All right. So in order to get to vaginally deliver a baby, you've got to have a couple of things. You've got to have a cervix that is faces or ripens, so that the cervix, the muscles around it can pull that cervix apart and allow the baby to go through, and then you got to have muscle contractions to push it out. So sometimes we want to deliver a baby, but the cervix just won't cooperate. So you've talked about, so effacement is referring to the softening of those muscles that are right around, or the tissue right around the cervix. So 100% effaced would be no change at all. 50% effacement you see there, you want to be 100% effaced before you start to try and push that baby out. So we use prostaglandin products to do that. We're going to induce a mom. She's not effacing, so then we are going to do that because we're going to put her in the hospital in a day or two and give her oxytocin and have her deliver. So this is for vaginal delivery. So you'll see several different kinds. There's Prepidil, there's a picture of it at the bottom. The next page you'll also see Cervidil vaginal insert, and then Misoprostol or Cytotec. So there's 3 different products. They're all a little bit different. The Prepidil is, it's in a syringe that's inserted up the vaginal canal and then put around the cervix. It's a very thick, tenacious gel that will stay in place. And so then that will prompt, and once that cervix effaces, usually contractions will start from there. If oxytocin is going to be used, if you're going beyond what the woman is able to produce, then delaying that oxytocin until 6 to 12 hours after the Prepidil, so note that. The Cervidil vaginal insert is probably more commonly used because it's reversible. So it is inserted, it's time released, slow and constant rate, so if the woman starts to efface quickly and goes into labor, you can remove this. So this is probably one of the more common ones. Can be left in place until active labor begins or for up to 12 hours. The advantage is reversal and removal. The last one, let's see, I'm going to point out. So you've got prostaglandin E2 and E1 that are different products. So Misoprostol is a tablet. So you got an insert, you got a gel, and now you have a tablet. Same process. Insert it up by the cervix, leave it there. Here you have to delay the use of oxytocin for at least 4 hours, so kind of keep those in mind, yes.
What if she's already dilated? Do you still use this?
No, no. So you're only going to do this if they're not effaced. Have you talked about oxytocin yet? You haven't talked about labor. Okay. So oxytocin we're going to use if contractions are not progressing like we want, and maybe we've given them something to ripen the cervix and contractions have not started. So if we want to get the ball rolling, then we're going to start with very small amounts. This is an IV infusion, and we just dial it up until we get the contraction pattern that we want. The downside is overstimulation of the uterus. So you can cause uterine tetany, you can rupture the uterus. So this is going to be on a pump, and it's going to be monitored as to progress, how's the fetus coming through it, all of that. So you'll see blood pressure, heart rate, contraction pattern, fetal heart rate, fetal distress will all be monitored. And then the adverse effects are listed there. So postpartum hemorrhage, we can also use that oxytocin. So after a woman delivers, we want that uterus to contract because we want it to expel the placenta and any of the tissue related to pregnancy. We want it to get rid of it. We also need it to stop bleeding so that uterine contractions will also decrease the bleeding. If you don't, then they can suffer quite a blood loss. So oxytocin is first line. That's prevention. Management, we go to the ergoalkaloids. These are old drugs, been around a long time, and they're vasoconstrictors. So that ergonovine, maleate, and methyl ergonovine are methadone. 50, 60 years those drugs have been around. So they're used parenterally. Side effects are frequent. The nausea, the vomiting. So you just had a baby and then this is what we do to you. Headache, dizziness, chest pain. They're hypertensive. If they've got underlying vascular disease, you can worsen it with those drugs, yes.
The prevention for hemorrhage, is that something that's given to lots of women, or like when would you use it?
Not my area, but a lot of women will be on oxytocin, so they'll continue it for just a short period of time after delivery in order for that to happen. The other is the nurse comes in and massages your uterus to get it to stop the bleeding. That's my knowledge. Anybody else have any other?
The reason I asked is because I looked at my records and they gave it to me and I had no idea. I mean, I don't think there was anything that was going on.
I bet you most women get
They
it.
just did it?
Yeah, because you've got control over the doctor has more control. If you've got a normal delivery going, then you've got a lot of control over it. Yeah. Yes.
Just in case if something does go wrong, you already have that in your system, is that why you didn't give it to you?
Well, it helps with that. It helps with that bleeding after. So those are good questions to ask when you go through labor. When you cover labor. Carbaprost is probably more commonly, maybe more commonly used because it doesn't cause as much trouble side effect wise. It's a longer duration of action, and it can be given repeatedly if needed. So you might ask them which drug is used more often. But look at that caution in women with asthma. It can cause uterine rupture. And then surgery, removing the uterus would be the last resort if you can't stop the bleeding. Okay. I only have UTIs to cover. Any questions about labor and delivery? So let's talk about UTIs. They're very, very common. And we approach them differently than we do women who are not pregnant in terms of our aggressiveness in treatment. So if you look down under asymptomatic bacteriuria, is that this happens in about 2 to 7% of pregnant women, but most of them, a majority of them, will go on to develop a cystitis. And a higher percent of them will go on to develop pyelonephritis. So asymptomatic bacteriuria has been listed as a risk for like preterm labor and adverse outcomes. That cause and effect is not well established, but if they get pyelonephritis, it can have adverse pregnancy outcomes. So we want to avoid pyelonephritis. So we're going to treat these women, whereas a non-pregnant woman we may not treat. So risk factors are things that you might consider if they've had a frequent history of UTIs, if they have diabetes, they're at higher risk. So without treatment, 70 to 80, or with 30 to 40% will develop a symptomatic UTI, including pyelonephritis, and the risk is reduced by 70 to 80% if we treat. So, small amount of women, high risk for progression to active disease. Eradication leads to a high recovery. So that's why the data is behind it to treat. Okay, next page. So what do you use and how long do you treat? The consensus on treatment is more probably come out of experience than you've got studies that recommend it. But most of the time we're going to treat for 5 to 7 days for an uncomplicated cystitis in a woman. So if you look, a lot of these drugs, a couple of them, they concentrate in the bladder. So if you remember, go back and read about UTIs from GU. The nitrofurantoin and the cephalexin are drugs that systemically don't do a lot, but they concentrate in the bladder. So that's what makes them good in treating cystitis, particularly nitrofurantoin. Some of them, and this is the part that I would really focus on, is when to avoid them, when to use them. If you suspect pyelonephritis, then you'll never use nitrofurantoin. Okay? You would not use fosfomycin. Remember, fosfomycin was that one-time drug, 3 grams, one time. Okay? But it's very good at local infection because it's all cleared by the bladder, the kidneys put in the bladder, kills the bug. But it does not help you in a pyelonephritis. There you've got to have a broader spectrum, greater systemic effect. So trimethoprim sulfamethoxazole, don't use it in the first trimester, don't use it at term. So that is a really important one because it's a common go-to. We're not going to use the fluoroquinolones. You don't see them on here at all, do you? We're not going to use tetracyclines at all. So know the drugs we're going to also avoid. Amoxicillin clavulanic acid is probably a good one to use. Cefpodoxime, cephalosporin, another good one to use. Amoxicillin by itself probably is going to have limited use, just because of resistance patterns. You always want to follow these women up and find out, did you clear the infection? And you want to address recurrent. If they have recurrent UTIs during pregnancy, then you're going to want to put them on a suppressive therapy. So here you can use nitrofurantoin or cephalexin at bedtime, or if it always seems to follow intercourse, you can do it post-coital antibiotic. Those are the concepts I want. Be sure you know the antibiotics you can use, those to avoid, and when to avoid. Last, pyelonephritis here, if you look back to the pyelonephritis discussion we had in GU, these are similar drugs. Broad spectrum of antibiotics, powerful ones that we're going to use for treatment. So it's going to be the broad spectrum beta-lactams, that would be that piperacillin, tazobactam, the 3rd and 4th generation cephalosporins, or aztreonam. Okay. That's pregnancy. Okay, tomorrow we'll do lactation. All right, thanks for your assistance.